All right. For our last speaker of the day, I would like to introduce to you Dr. Chinthala. Dr. Chinthala is an adult and geriatric psychiatrist that currently practices in the greater Indianapolis area. She has practiced as a staff and consultant psychiatrist in multiple state hospitals, acute care hospitals, the VA in Indiana, and other older adult hospitals. Dr. Chinthala has provided supervision and education to both medical students and residents through Indiana University School of Medicine. In 2008, she founded A&G Behavioral Health Services. Since founding, Dr. Chinthala has been providing adult and geriatric psychiatric consultation services to multiple extended care facilities. Dr. Chinthala has received a top doctor in Indiana recognition annually since 2019. But before Dr. Chinthala gets to come on the stage, I'd like to introduce her right and left hand, Miss Brittany. Brittany.
Hello, I'm Brittany, the right and left hand. I'm Brittany Modisett in all seriousness, and I've been the clinical coordinator for A&G Behavioral Health Services since its beginning almost 15 years ago. And you're probably looking at me like I don't look that old, but I met her when I was 18 as a psych tech, and when I got out of grad school at 24, I've been with her ever since. So as Amanda's already said, your next speaker is Dr. Chinthala, and she is an adult and geriatric psychiatrist out of Indianapolis, Indiana. Mainly at this time, she is the CMO of an 80-bed inpatient psychiatric facility, and we also have multiple nursing homes that she provides medication management in. So you're probably wondering why we're standing here, why us? There's a lot of people that write psychotropics in nursing homes these days. What we like to think that Dr. Chinthala, the way she practices, she is special. And obviously different people have different definitions of the word special. I will say that for the most part, people we work with stand behind what we do, and they think what we do is best clinical practice for their patients. There are also some folks that, how do I want to say it nicely, don't stand behind what we do or think what Dr. C is going to talk about today is necessary for their patients and would like to tell us to hit the road. So obviously, generally you don't associate the term deprescribing with a physician. Typically in healthcare, as we all know, a nurse will call the physician. They're going to report X, Y, and Z, and in return they expect a medication order to give their patient. Well, that's not how A&G operates. So typically with us, when there is an issue, staff members are expected to call our call center with a lot of specific information. And that live call center gets to ask questions back. That is me. So when the staff calls, they are expected to tell us whether it's a behavior or an emotional issue they have to describe before anything gets to Dr. Chinthala. They have to be able to tell us what happened environmentally, what their staff roles was, what the staff interventions were, what's actually documented in the chart at the time they call us, when their most recent labs were, vitals, all of that has to be given to us. This lady over here, she's never written a blind medication to a patient, and she will not in the future. So really today our goal for all of you is just to understand why Dr. Chinthala does what she does. And if your in-house psych team, whether it's a psychiatrist or a psych NP or your primary care physician, whoever's writing the psychotropics, that you all can have a baseline understanding of what it is they're actually writing them. And if they're not doing some of the things we talk about today, that you're able to go back and have a healthy conversation with them about these things. So it is truly my pleasure to introduce to you this woman. Professionally and personally, she's amazing.
Thank you, Brittany and Amanda. So they spoke a lot about me, but let me see how much I'm going to justify this time. First thing is, good afternoon, everybody. Hope you guys are not tired. It's end of the day, and I know ready to almost wrap up for the day, but I still hope that you have some space in your brain to accommodate some more points which I'm going to talk now. And actually, I'm not a speaker or go and talk much, but this was like I was asked to share some of my information which I'm doing on a daily routine in my practice. So I just wanted to share whatever I learned through the patients and my clinical. This one?
Just a little bit.
Yeah?
Yep, you're good. And then back up a little bit on the microphone.
Yeah. So, hope this can hear everybody? Is good now? Okay. So, as I said, I'm not really used for the speaking, but we'll just bear with me until we get into the track. So, I was asked to kind of share few of my clinical experiences. So those are the things which we kept as a slide, and then I'm going to talk now. So the biggest issue right now, and everybody's talk, is the psychotropic medications in the long-term care. When should the psychotropic medication should be used, and why should they be used, and what should we do before using the medications? Those are the things we are going to talk. And before we get into the medications, usually that's what Brittany explained. We try to get some more information. So getting the vitals, labs, and what was the reason they are calling us, and what kind of stuff happened with the patients, and documenting what the issues patient was having, and also what are the environmental and behavioral factors and the interventions they did before calling the psychiatrist. So the one we always, everybody says that any issue, first they call the MD, but when it comes to the psychiatry and the psychotropic medications, I usually say that I'm the last one to call, not the first one. So this is the way I was kind of having that mindset that calling a psychiatrist is not the first step. Why? Because we had to get some information, and all other things needs to be looked before we consider the psychotropic medications. And labs. So we always have some issues with the labs, why labs are so important for the psychiatry. And then sometimes in the long-term facilities, I know we have limitations, but the labs do care, and they do play an important role in before we start the medications. So the labs are important for acute versus maintenance. Why? We'll just kind of talk briefly. And why the labs are important and which labs are important, and is the kind of the key point here to know before the medications we prescribe. And everybody knows the basic metabolic panel means all those electrolytes: sodium, potassium, chloride, bicarb, and creatinine. We get it. Especially in the elderly patient population, the electrolytes are more important, and then it will be so quickly they get the fluid electrolyte balance. So it's very important to monitor sodium levels, potassium, and then all the calcium, BU, and creatinine. And coming back to CBC, this complete big picture, what is like you get the hemoglobin count, the platelet counts, how they are important, because some of the medications influence the hemoglobin platelet count. So, and also we had to see if there is an infection, is there, or something else medically going on. And the TSH, everybody knows thyroid plays an important role. And if there is any depression, ongoing depression, been long term, and been there, antidepressants, nothing is working, we have to make sure thyroid. And then the thyroid is also influences many other things. So weight gain and weight loss, so it's better to check thyroid levels also regularly. And coming lipid panel and the A1C. And usually hypercholesteremia and hyperglycemia, those are kind of risk factors for the diabetes and coronary artery disease. And especially when we're trying to get the psychotropic medications, because they are kind of they contribute to the significant metabolic changes. So it's important to know the levels before we start the medications. And liver function tests, of course, important because most of the medications are metabolized by the liver, and especially elderly patients, so there is a compromised liver functions, and when we are starting the medications, we have to make sure they are metabolized by liver or metabolized by kidney, and it helps us to guide the lower dosage and the monitoring. And ammonia levels, this is because especially in a nursing home, long-term care facility, most of the time the Depakote is used for many reasons, and there is a barrier. They don't check the ammonia levels, but how it is important is, higher ammonia levels can cause, more confusion, and then leads to some delirium, and then leads to the falls. So when somebody is with higher ammonia got confused and getting agitated, don't call the psych. You can call the psych, but you have to work on getting that there is a high ammonia issue needs to be addressed too. But without addressing high ammonia level and getting a psychotropic medication interventions from the psych team is not going to be helpful. So that's the reason the labs are going to be important before we implement the psychiatric interventions. And vitamin B12 levels, folate levels, everybody knows these are all also important and routinely we check, especially dementia patient populations, if they are low, and that kind of causes the risk for the cognitive impairment and some more, worsens the dementia in the long term. So we try to check B12 and folate levels too. The other thing, urine culture and sensitivity. Even though it's a simple test, but most of the times we push it aside. But it kind of helps the psychiatrist in many ways, because when there is a urinary tract infection is going on, and that is most common in the long-term facilities, we think it's not really, it will, within 5 to 7 days it will get better. But sometimes, the urinary tract infections can lead to sepsis, or sometimes urinary tract infections lead to delirious conditions, or sometimes, with the UTI, they make it more agitated, anxious. So it just helps us which direction we have to move on to address the problem. And the lithium and the Depakote levels. Lithium and Depakote levels, like especially, as I said, the Depakote is commonly used in the long-term facilities. So even though we don't want to use the lithium level, but if the patient's having a chronic, long history of bipolar, they've been on the lithium for years, and they are admitted to the facility, we don't have a choice. We need to continue because they don't like to be changed. So, and lithium levels, and it has a very narrow threshold. So what happens is, if there is any toxicity occurs, and then they will become confused, delirious, and end up having the behaviors. So keep monitoring lithium, Depakote levels also important in the labs. So after all this, we're getting the vitals, the labs, and looking out any medical conditions, or just ruling out the medical conditions are not contributing to the behaviors, and all the staff interventions, and then everything was implemented, but still having some issues. So then the psychiatrist or the prescriber comes into the picture. So I'm going to talk groups of medications very little, because I'm not going to talk in detail of the pharmacology, pharmacodynamics, pharmacokinetics. We don't need all those things. I just wanted to see, I wanted to kind of share few of my personal clinical experiences with some of the psychotropic medications. And also, it's not only the prescriber, and if the staff also needs to be aware, whoever is involved with the patient care. The first group of medications we usually do is pick up, the first thing is, and then recommend also everybody to go, is the SSRIs. These are the antidepressants. And then everybody, most of the nursing home patients, they say various reasons they'll be depressed, and then we try to, take care of the depression part and the anxiety part. So the frequently used medications are the Prozac, Lexapro, Celexa, Zoloft, Paxil, Luvox. Everybody is familiar of those medications. So what I'm trying to say is those are the common medications we use it, but we should not use, because we should use carefully, because these older adults and medically compromised patients cannot tolerate high doses as the adult patient population. And sometimes with the primary care or in second piece, they do the guidelines which exactly adult dosages are recommended. But the higher the doses, there will be increased risk of side effects than increasing the efficacy. So it's better. You should not think that giving high dose will fix the problem quickly. So that's something, there many people kind of get biased and then try to do the higher doses, which will end up having some side effects, especially the falls and the confusion. There are so many side effects of the SSRIs, but I'm just going to talk only few of things which are more important in the long-term care patient populations. One of them is the sodium, the low sodium, because most of the geriatric patients, the fluid electrolyte balance, they can be easily they'll become victim. Even if they don't take 24 hours, if there is a PO intake is less, the sodium levels get fluctuated. And the low sodium also increases confusion and some falls. So if they are already having the low sodium levels and you are giving some, then they think the patient is depressed, you start an SSRI, what happens is it further decreases the sodium level, which kind of increases there. More confusion, more falls, and sometimes it ends up with having a seizures too. So we have to talk with the primary care team or get into their attention, make sure that that kind of thing is fixed instead of just treating them with SSRIs without giving attention to hyponatremia. That's not something usually, we miss in a day-to-day things. And the other one is SSRIs recently. Previously, it was not known that, but it was being proved in a lot of the clinical and studies that they are contributing to the bleeding issues. So when it comes to the bleeding, it already, because it is not seen obviously. So there is internally a lot of things happening, and then they're losing the blood, and then they had also for any reason they're anemic, and you start an SSRI, and then you just make it worse and worse. So that's something also we need to. And then when they are becoming anemic, they become more fatigue, confused, and they have low energy. They get there is so many other things comes out. So we had to make sure that they are not anemic also. And of course, the biggest major concern is a cardiac. Because SSRIs also do increase the QTc interval. So when it is increases the QTc interval, and then it causes leading to the cardiac arrhythmias, which are already have some cardiac issues going on. And most of the long-term facilities, they have some or the other medical issue related to the cardiac origin. And now when I started my practice, Celexa was not really a big issue to start to go up to 40, but now they found it's 40 milligram dose level, it increases the QTc interval, and it's kind of a more toxic of causing the cardiac arrhythmia. So that's why now it come down to like they recommended only 20 milligrams, but still some of them prescribers they go up to 40. But in elderly nursing home patient, we had to look into that the small dose and then to avoid the complications or to induce the arrhythmias or anything related or worsen the cardiac problems which is already existing. And also that, and then when we give like a high serotonin, sometimes they make them more like anxious and more like overstimulated, and they'll get agitated. And sometimes when and they're also prone for the serotonin syndrome because their metabolism and everything is not as adult. So even a little higher doses, the older patient population is risk for serotonin syndrome. That's kind of another big thing. So it's kind of leads like needed definitely in ICU care when they have the serotonin syndrome. So the thing is, just wanted to make sure that when we pick up the medications, we had to look into those pre-existing conditions, not to aggravate the problem. And that's kind of the SSRIs. So when if they have a bleeding issues, and if they have these cardiac concerns, and if they have hyponatremia issues, so the SSRI is not the good choice, then what do we do next? So in the list next we have is SNRIs, and everybody knows there are serotonin norepinephrine reuptake inhibitors. So usually the most commonly which I use is like a Cymbalta and Effexor, because especially when the SSRIs they're not the good candidates for SSRIs because of the hyponatremia, GI, and then I'll try to pick up from this group either Cymbalta or Effexor. Again, of course, every medication has some risks and benefits. So before we are when you are using this SNRIs, especially like if I had to pick up Cymbalta, then we had to look into the renal functions because it's excreted by the kidney, and most of the time these older adult patients have some kind of a chronic kidney diseases. And then somewhere some of these impaired kidney functions. So we have to make sure that their GFR is good, and then they don't have any severe kidney diseases. So if everything looks normal, then I can pick up the Cymbalta as a choice of the medication for them. But if there is anything like if the kidney having issues, then Cymbalta is a not good choice, and I'll go for let's do the Effexor. So Effexor is another one, also SNRIs, but I think it looks like I'm missing the slide here, but let me see. It's going back. Okay, so maybe somewhere that Effexor slide will come. So anyway, the Effexor is the one usually we use. Like if Cymbalta is an ad, can help pick up Effexor. And that is a good choice for the patient who is having high blood pressure. It is a side effect of the high blood pressure, but if you're having a blood pressure issues, Effexor is not the good choice. But if they have a kidney has issues, but if you cannot pick up Cymbalta, I'll go for an Effexor. So we just kind of go it's not like a one simple rule. Okay, everybody has to be in Cymbalta or everybody has an Effexor. Just we have to go and see just the best interest of the patients. What's the underlying kidney disease? No, then Cymbalta. Having a blood pressure is no, Effexor is not a good choice. So like that, we just kind of judge depending on the clinical condition and the risk versus benefit. So then the other group is the tricyclic antidepressants, but this actually in elderly patient population, this is not at all not a good choice because of the side effects. Actually, their efficacy was good, but they have the side effects like mainly anticholinergic symptoms. What is the bladder retention, dryness of mouth, confusion, and the antihistamine sedative, more like sedation and confusion. And they also cause the orthostatic hypertension, which is a trigger for the falls. And then cardiac toxicity, because it kind of induces cardiac arrhythmias, which is that is one of the red flag for the tricyclic antidepressants for elderly patient population. So they are good was efficacy wise, but it's not a good choice for this patient population. Here I told the slide will be coming if XR. As I told, this is not a good choice for who has a higher hypertension or hypertensive crisis. And so we just kind of going group by group. And now they're coming into some miscellaneous antidepressants. In the miscellaneous group, one of the choice or more frequently I use in the long-term facility, and most of them use, is the Remeron 2. There are a couple of things. One is at the lower doses it acts like an appetite stimulant, and it's a little higher dose it acts an antidepressant, and also has some anxiety effect. And then the side effects are minimal, and the most of these medically compromised patients also tolerate well this drug. But as I said, just because tolerant, we should not give a high dose, because when you give the high dose, again, they'll have an orthostatic hypertension, GI bleeds, and some side effects. So it is a better tolerable at the low dose and given at bedtime, so that way anything with the blood pressure changes will not trigger the falls. The other one in the miscellaneous group is Wellbutrin, the safest alternative for patients who cannot tolerate SSRIs, SNRIs. This drug, actually, good thing is it does not affect the sodium levels, hemoglobin level, renal functions, because it's kind of a safest drug. Only the risk factor is seizures, and patients who have a already pre-existing seizure disorder, any kind, or risk for seizures for any reason, the Wellbutrin is no. So it's not at all a choice for the patients with a seizure disorder. And also for other patient population who has like a significant weight loss, and especially that happens in this geriatric patient population where they don't want to eat and they're losing the weight, but they're depressed, so they don't pick up the Wellbutrin, because you may be correcting the depression, but you're making worse their weight loss. So we had to just kind of go, risk versus benefits, the thing we had to think about that before we pick up the choice of the medication. Now that's all about antidepressants, which commonly is. Then the second group is the benzos. Everybody likes to use the benzos, but it is completely big red flag for the elderly patient population in the nursing home. The good thing about the benzos is, it's easy, it's fixed, make them sleep, and the problem gets over for the staff and everybody, but it's not good for the patients at any cost. So this benzodiazepines is, because the side effects are so much, because they go and directly act in their CNS, central nervous system. So there increases their confusion, there increases the worsens their memory, and they have they have gait issues, and then the coordination issues, and then they make them more of risk for the falls, and then leads to fractures, and then it's all. So even from the outpatients, benzos in elderly patient population led to a lot of the car crashes and accidents. So it is not at all a good choice for the elderly patient population. It's not good for anybody, but elderly patients is like a big no. And then the reason is because, as I said, it helps to fix the problem quickly, but it does a lot of damage because of the side effects. Like causes hypotension, falls, sedation, respiratory suppression. And sometimes when we think that benzos make them calm and sedated, but does paradoxical effect, worsening the agitation, worsening the aggression, worsening the anxiety too. So we don't realize, we use the benzos to calm them, and why these things are getting worse. Let's give more of Ativan or more of no, because it has a paradoxical effect too. That's we need to identify. So I will always say no to benzos, and but if there is no benzos, how do we address their anxiety? How do we address their some of restlessness or some agitation or aggression, we'll try. First thing is identify the cause, what's causing it. And if something is not really keeping a patient at risk for safety or not having any risk to others, so let's try. We had to do the non-benzos to just give some comfort care, like Visceral or Buspar. So the Visceral will kind of give you same like a sedation, like not like benzos, but it kind of gives immediately, it acts and then just calms them down. But at the same time, this we should not use for long term. And good thing about the Visceral is it is available as a tablet, the capsules, and also if needed, sometimes if they don't take PO, we can give the IM form. And sometimes if the anxiety is there, but not like we need to address immediately, so we can try like a Buspar. It is like a safest medication, but sometimes it works, sometimes it doesn't work. But if it works, it's a good one. But we'll take it. It won't harm. So we will give it a try, and then some mild anxiety, moderate anxieties, over the time they will get better, even though the Buspar won't make like immediately sedate or calm down. But it is a slow, but if it works best. So we had to try the things, which other alternatives which can kind of balance the safety and address the issue. The other one I use usually is in the Neurontin. So this is actually works better in many issues. Like even though initially it is approved for the seizure disorders, but later on it is approved for the mood disorders and then some anxiety disorders. Later on in the long-term facilities, we've been giving to address the behaviors, agitation, aggression. So they do not cause like a sedation, and they do not make them confused. So at least the problem related to the physical aggression or verbal aggression, anxiety, agitation, restlessness can be addressed, and the Neurontin will take care of it. It's kind of off-label use, but it is helping, and then kind of helps not to go for the benzos. So at least taking care of the job of the benzos. So we should utilize the Neurontin instead of benzos, because not having the side effects as a benzos. Again, the only thing Neurontin is, because in elderly patient, I said most of the time they have a compromised kidney function. So it is excreted by the kidney, and we had to look there what is GFR, how the kidney status before we start the Neurontin. And as I said, for the anxiety and agitation, so like antidepressants means it's misnomer. Oh, it's only for depression. No, it can be treated for anxiety too, and also for agitation. So it may not do as immediately as other medications, but keeping him on a low dose if there is somebody getting easily agitated, easily getting anxious. If they kind of start an antidepressant, that will take care, and then kind of will not lead to a situation where you need to give the PRNs or any other anxiolytics. Okay, now coming back to another group of medications which we use commonly for the sleep aids. So pretty much everybody in the nursing home, one or the other sleep aid. Of course, they have been, because number one, they are suffering with medical issues, and they've been away from home, and there's so many things. So they like to have a sleep aid. And what we usually, the most common sleep aids we use in the long-term facilities are trazodone, the doxepin, and the melatonin. So if somebody does not have a insomnia or a chronic insomnia history, and just because of the situational, like being away from home or being something, we can try natural supplement with melatonin. But if it doesn't help, and then even if you try melatonin, we always try the low dose. Start low, and if it doesn't help, go up. And then we don't encourage going more than 10 milligrams. And then if that fails, if that's not really helping, then go for another prescribed medicine like a trazodone or the doxepin. So even the trazodone also, we should not do like adult dosages. We should to do on not the lowest dosage. If it doesn't help, we can go up, but you cannot keep going up 50, 100, 200 because it's not sleeping. Because higher doses, and especially in adult patient, again causes the orthostatic hypotension, which causes the falls. So our goal is to prevent the falls in the long-term field, because that is the commonest thing happens on a regular basis for many reasons. But one of the thing is medication. So we had to be careful. Any medication is triggering the falls and should be in the red flag. And we had to or monitor cautiously. And the others, then okay, the trazodone didn't help with us reaching to the therapeutic dose, and then or having some orthostatic hypotension, they're having a falls, or they are already pre-existing falls, and adding trazodone might increase the falls. Then don't go for an alternative like a doxepin, which can will not do any changes with orthostatic hypotension. So that way, patient gets sleep, and then also we prevent the falls. So just again, I'm saying again, risk versus benefit. So what is, how do we prevent, and what are the choices we have, what are the tools we have we can use before having some side effects or before having the patient's risk for any other side effects. And the two sleep aids which usually I do not use, and I do not recommend also anybody to use, is the Restoril and Ambien, because they are not really good for the elderly patient population, because that pretty much comes like they do the same thing like a benzodiazepine, and there will be like a more confusion, and their sleep cycle will be messed up, and then they won't work for a long time, and then, as I said, they are not really good for long-term use in elderly patient population. But those can be used in acute care settings for an emergency basis, or if they're in the hospital, acute care, or suffering something, and then they can use as needed and for short term, because there is a more monitoring will be there in the acute care setting than the chronic care setting, the long-term settings. The other group of the medications which I'm going to talk is the mood stabilizers. So the mood stabilizers is the another group of medications which we take a lot of help of mood stabilizers in the long-term facility. Even though the mood stabilizer is approved like a bipolar disorder with mania, depression, but now we use for many other conditions. Like anybody with the dementia with the behaviors, or any delirious patient with the behaviors, or any kind of aggression, any kind of agitation, any kind of hostility, anything which is causing them in distress, we try to pick up the mood stabilizer. We'll just wants to pick up one of the mood stabilizers. The most commonly used mood stabilizers are the Depakote and the Lamictal and Tegretol. Of course, everybody knows there are so many people are on the Depakote, because one is it's available in the liquid form, it is available in the sprinkles. So even though some people, the elderly patient, they don't want to swallow the tablets, they can give some liquid form. It has some good things that it helps with that, but it has some things which we had to be very much careful when we are doing this. When we keep the patient on the Depakote. One is for the Depakote, we had to get the labs. I know there is some limitations with the labs in the long-term facilities, but there are two reasons we need to get the labs. One is we need to monitor their platelet count, patient's platelet count, because it decreases the platelet, and if the platelet count goes down, they will be at risk for the bleeding. So we need to monitor that, and then also we need to check the ammonia levels, which does not happen many times. And then that, as I mentioned, that high ammonia will cause a confusion. Again, confusion leads to anxiety or agitation or behaviors. And we usually, in our routine practice, when there is high ammonia levels, I do not get into the psychotropics until the primary care fixes the ammonia levels. I said that first thing is treat with lactulose, or they get the ammonia levels back to normal before we use the psychotropics. But if a patient is getting very agitated, then a safety concern comes. They can get a one-time order as needed, like just until the ammonia levels come. So, because when this, as I said, this not contributes to the falls, which is another one we are worried, agitation and restlessness. So it's important to correct the ammonia before we implement the psychotropic medications. And also, like, it's a, somebody has a good liver functions, but most of them have this compromised liver functions in elderly patient populations for many reasons. So monitoring the liver functions is also important. And as I said, leads to the platelet count, lead to thrombocytopenia, which is in turn causes the risk of bleeding. So it's always recommended and then to be cautious. So checking the blood levels routinely, and at the same time getting checked CBC and ammonia levels if needed. Okay, now this is kind of the monster of the antipsychotics long term. It's like a totally, we don't want to open the door for antipsychotics, but there are sometimes we have to take the help of the antipsychotics. So again, never ever the antipsychotic is the first choice for any reason. So that will be the last one to be considered. But before considering antipsychotics also, as I said, we had to look for what the environmental factors kind of triggering the behaviors. Or this patient is really a psychotic because of the pre-existing psychiatric diagnosis like schizophrenia or schizoaffective. Or this is a psychosis is just related to the current condition, like being delirious, he's psychotic. So we had to figure it out. And also the environmental factors, what the behavior is related to anything related to the environment, or anything related to the staff triggering, or other patients. Sometimes the patients walk into other patient's room and then another patient will hit the other patient, then it's a reportable incident. Don't go and jump and give the antipsychotic medication to that patient because the patient hit the other patient or it's a reportable incident. So those kind of things needs to be verified before we go for the antipsychotics. Unfortunately, these antipsychotics have the sedation effect is there strong, and that is the reason everybody tries to jump to antipsychotics to calm down the patient. And that is something we do. In my practice, I do not do it. So my right and left hand, she kind of takes care of all that clean stuff. Then only it will go to the antipsychotic. So, but in the real world, it's not happening. Anything, patient is agitated. Okay, we have to calm down. Get an antipsychotic because it's a lot of sedation. Antidepressants would not have a sedation effect. Mood stabilizers does not have a sedation effect. So the antipsychotics only has a stronger sedation which can help as an immediate tool to calm the patient. Yes, we can do it, but that's the last one when there is a really in danger, either the patient, other patient, or the staff. So until that time we need to find, and then they need to work on what's going on, what triggered, how can we, do without taking the help of the medications, I can address the issue. And then of course vitals, sometimes they are dehydrated, sometimes they're having some fever. When they're fever, they cannot say I don't feel good, I feel restless. They kind of act out with the behaviors like a kid. So we had to make sure they're not in a comfort zone, there's something is going on. Then and again, other thing is in the nursing homes, most of them, I think every person, maybe out of 10, 2 people may not have a diabetic, but everybody is almost like having the diabetic. They are diabetic, and their sugars goes boom, up and down. And then their diet is like, they don't have any, everybody eats the same kind of food, so their sugars goes up and down. And then when they're high hyperglycemia, sometimes they make them, when they're dehydrated, when they have high sugars, they get more confused, agitated, dehydrated. So we had to check the blood sugars is also important before we get into the medication on the board. And most of them are we see they'll be wearing the oxygen, only the tube. There is no oxygen in the oxygen cylinder. So when they have the hypoxemia going on for hours, and they get anxious, and they get agitated, they get confused. So these are basic things we need to check. The staff needs to check before call for the medication. Because you guys can stay in a room where there is no oxygen for 2 minutes. You guys see how miserable you guys will feel. You'll try to hit somebody, whoever comes in front of you. So they cannot explain. They will be like, they don't know what's going on and they don't know. So they will kind of exhibit, it will come out as a behavior. So these are the things we need to look at carefully. And as I said, vitals is important because we don't want to have some low blood pressure, because some of these antipsychotics causes the blood pressure issues too. And if you're already having a low blood pressure, you start on a medication and then blood pressure go down. So we have to make sure that vitals are stable. And the labs, we need to check in the labs. And most of the time it's a big challenge in the nursing homes to get the current labs. So they have a labs like 3 months old labs, 6 months labs. Those are not called as a current labs. So we try to request them because the labs are important also just to rule out infection or rule out the dehydration and rule out is anything else going on medically before we consider an antipsychotic. And the behavior also, like just don't try to use this general word behavior, getting agitated. So we'll always ask them to document what kind of a behavior, what triggered the behavior, what the behavioral interventions you did it, and then come to a real term. If you need an antipsychotic, delusions, hallucinations, paranoid. Then when you describe, somebody says, delusional. If the patient is delusional, he thinks he's the president of America, we don't have to treat because he's enjoying. So don't treat that delusional. Let him enjoy being a president. So we don't have to worry about it. At the same time, paranoia. And then they think that, they have some money, somebody stole it, but they're talking. We don't have to get immediately an antipsychotic. So those are the things which we triggers for the antipsychotics is command hallucinations or safety concerns. They're hearing the voices, saying them, they're saying that person is going to kill you or kill somebody, or you have to go and hit, and then they're going to go and hit. Yes, you need to get an antipsychotic that time when there is a safety concern or really a psychosis symptoms going. Not for the behaviors which are not related to the psychotic symptoms. So the documentation is very important before we get an antipsychotic for the justification of the medication. So as I said, we had to kind of rule out all the medical conditions before we get into the antipsychotics. And the other thing is, as I said, not only the medical, even the pain, everybody, like as I said, most of them, they'll have some chronic pain, acute pain, someone. When they have a pain, they'll get agitated also, will get anxious also. So is it addressed before we get an antipsychotic? So because these are the common things we kind of come across on a day-to-day in the long-term care. So because, if there is a pain you address, you eliminate the use of antipsychotic on that particular situation. So, and those are kind of a basic things, but the special considerations are there before we consider, if there is we took care of everything we did, everything the patient is really actively psychotic, that psychosis has to be under control, but we need to look like, their cardiac conditions, because most of these antipsychotics has an impact the QTC interval, which causes cardiac arrhythmias, and then it'll end up having and then they're especially in the geriatric patient, of course, it's a black box warning for any antipsychotic. So, but still we had to use in a certain special situations. Unfortunately, we don't have enough data. The clinical study happened in the dementia patient population much, but it's coming up now. But anyway, the old school it's antipsychotics is block warning for an elderly patient population, especially because of cardiac issues, blood pressure issues. And they will have easily they get into hypertensive too. So, and then which triggers a fall. So adults, even if they get hypertension, they do not worry. We don't have to worry because it won't trigger a fall. But elderly, yes. And the falls is the most commonly ongoing problem in the elderly patient population. And that's something we have to prevent as much as we can in all directions. And other, as I said, like these metabolic concerns, because all these antipsychotics are there, will mess up with the metabolic issues, mainly increasing the lipids, increasing the glucose levels, increasing the weight gain. So those again kind of triggers like hypercholesteremia, diabetes, cardiac, problems with the dementia, and all those are the risk factors for the chronic problems. So we don't want, already they have a diabetes, they have a weight gain, they have a high cholesterol, and you just do these antipsychotics, but there is no choice, for short term. And then we need to monitor their metabolic panel to make sure that we are not ignoring those underlying metabolic issues. Okay, this is another one, the most common thing which we ended up using antipsychotics in the long-term facilities is the delirium. So for that, of course, old school and from the day one is going to use the Halidol, and then Halidol is proved as a good antipsychotic for treating the delirium. So the delirium is, most of the people, they get confused with the delirium and dementia. So delirium it's an acute problem. It's a short term. So it's like, there is a disturbance in the conscious level and there are altered coordination, and it just happens within a short period. Some people get delirious within 24 to 48 hours if they are dehydrated, if they have a UTI, or if they have any other medical condition. And, sometimes the underlying infections, we don't know, but it will end up sepsis and they'll go to the delirious. So during those conditions, yes, they'll become like psychotic, agitated. And once we know that it's for sure for delirium, and then we could use the Halidol depending on the severity of the clinical symptoms. So I usually try to use them like as needed, like if needed for 24 hours, if needed 48 hours, if 72 hours. Sometimes things will settle down 24 to 48 hours, well and good, we don't need it. And sometimes it will kind of needed more, and then even if you use the PR and we just go with the lowest dose, sometimes that helps them to calm down or just coming out of that situation for a short period or that immediately. So once it kind of controlled, we don't have to use it. Again, we'll stop it but sometimes some of the infections, they can, like pneumonia or UTI, other infections, may need like a 7 to 10 day period. But even though first 3 days we are in delirium and they're having behaviors, but later on also still they're having some issues, we do use the, we can use for a short period. And then, okay, we had to start this and then stop date. That's important. If not, the nursing also has to get into the prescriber's attention. So in the olden days, what has happened was this Halidol was started and continued for weeks, months and years, where most of them ended up having this cardiac issues, and then there is a mortality rate is increased in the patients who were taking Halidol and with already pre-existing cardiac conditions. So the short-term use, small doses, will be more, they're tolerable, will not cause a side effects, and then it kind of take care of the acute condition. So I'm telling you that situation where there is a line came, just ignore that line. So antipsychotics, if you had to use, everything fails. This a patient is psychotic, so there are in my practice, I usually had a good luck, and then also least side effects is the Zyprexa, the Risperdal, and Abilify. So the Zyprexa, then we have studies, and then it does not do the much with heart. So anybody has a cardiac issues, and that's the most commonly worried issue is a cardiac. So the Zyprexa is a safer alternative for the cardiac conditions, and again, I guess low dose for short period. And the Risperdal is because we have a solution form to Risperdal sometimes when they don't take the tablet. So that also helps with the severe psychosis or agitation. And I usually pick up Abilify if there is a more of depression coming with and then that's kind of lead to psychosis, or they've been depressed, never been treated depression, and that turned to be psychosis. So we just kind of try to see, because that's also more tolerable and having less side effects. And any antipsychotics the biggest concern is extrapyramidal symptoms. Usually, for the same dose, adults do not get an experiment. They may not, they have a high threshold. But in elderly patient, for the same dose, what we're giving adults, sometimes they are at risk for the EPS. What is this EPS? It's like there's a group of side effects: dystonia, akathisia, pseudoparkinson. These are all called extrapyramidal symptoms, and which are kind of are due to the dopamine deficiency. So when you're blocking with the dopamine, then the people have some side effects, which looks like Parkinsonism means just like same thing. Slowed movement, muscle stiffness, shuffling gait. Oh, and then we had to get. Sometimes some staff says, "Oh, he has a Parkinson's disease." No. So first we had to rule out it's not due to the antipsychotics. Then you can refer to the neurologist or primary care if still some problem exists. Same thing, dystonia. Dystonia is a stiffness, and most of them they'll get confused with this dystonia, akathisia, tardive dyskinesia. So they're kind of terms which have a particularly having, there's a muscle contraction, that's kind of tonia, dystonia, and they have a repeated twisting movements. And then akathisia, that's like restlessness, inner restlessness. They cannot sit for even for a second. And so these are like acute symptoms. So, and we had to, because the psychiatrist is not in the building, so the nursing staff and the other staff will be there. Whenever they can notice, they can just document and get into the prescriber's attention. And there are, for short-term use, these are the side effects. But there are sometimes in the patients who already have a diagnosis of schizophrenia or chronic mental illness, been in the state hospitals for a long time, may have been on antipsychotics. Sometimes when you're changing the adding the medications, they'll develop a tardive dyskinesia. It's a long-term side effect. Those are it's totally a different group. Like from top to bottom, you'll have some side effects like sucking, smacking lips, jaw movements, involuntary extremities, trunk area. So it's it's a group. So that TD was once upon a time not treatable. It's called tardive dyskinesia. But now we have some approved drugs, but we're still not using in the long-term facility. But acute symptoms of the extrapyramidal symptoms, what I said, dystonia, akathisia, pseudoparkinson, they are treatable. So we have some medications, to treat the side effects. Because if the patient is getting better, not having any hallucinations to kill somebody, but he's having some rigidity or some tremors. So, because the medication is helping, but he's not tolerating the side effects, let's give some more comfort care addressing the side effects. So we usually pick up the cogentin or amantadine, Artin, and the lower doses. So after you try to take the help of the medications to address the side effects, if still have some side effects there, so we'll try to cut down the dose and see. Or or we need to switch to the other medication, because each one has a different capacity to metabolize the drugs. So one tolerated doesn't mean that other will tolerate. So we had to go, it's kind of patient by patient. And so decrease the dose, and with a small dose, if the patients are under good control, we don't have to worry. But if the patient's symptoms are coming back with a small dose, then we need to switch to other medication to see whether they are going to be effective. So only the side effect of these medications, because we are trying to treat the side effect of the medication, but this medication also has some side effects, especially anticholinergic symptoms, and those are more common in elderly patient population. So we had to look, there is already dryness of mouth, it's getting worse. There is a prostate cancer, the prostatic hypertrophy, retention of urine. You have to think because it causes retention. So we had to kind of just look and go according to the patient thing. So it just, again, end of the day, what is the best interest of the patient is the call we had to take. And the other issue we usually face is just started psychotropic, so the family or somebody we read it's a black box warning, we don't want our family, we don't want them to die, blah, blah, blah. So we cannot prove whatever it is happening. If we have to prove this medication is causing this side effect, the only way to reassure the patient or the family or the staff is, I'll just hold the medication. So if there's anything you are noticing, which is not related to the psychotropic, you're noticing, we know that it's not due to the medication. But for your reassurance, you hold the medication. If that disappears, it's not. If that disappears, it is due to the medication. If that still persists, then you guys can say that it's not due to the medication. So that's the only way we will try to buy reassurance and confidence from the patients. Hold the medication. If the side effects is not and they're fine, then we'll continue the medication. So it's just like, it's easy for the psychotropics. The good thing about it is they won't kill the patients. And the side effects is when you stop the medication, the side effects will disappear. So we always try to reassurance patients or family, give a try if needed, and address the issue. And if they cannot, we'll stop it. And the good thing is, as soon as you stop, things will disappear. So that's kind of we wanted to get some reassurance from patients and family to make sure that not to panicky about the side effects or the medications. The summary. So long-term care patients need psychotropic as the last intervention. It is not the first call for the psychiatrist or the provider who is taking care of the psychotropic medication. It should be the last call. And before considering a psychotropic medications, we had to explore all the possible conditions, interventions, where we can avoid the medication use. And if all these interventions have failed, if there is a necessity comes, we can use, this a golden rule is, low dose, small dose for short periods. So usually psychotropics are bad causing side effects, but when you use them appropriately with the small doses for short periods, we can minimize a lot of the side effects. So that's kind of the take-home point with today's presentation. Now it's a questions.
What would you recommend for a geriatric male with exaggerated sexual behaviors in a long-term care?
Yeah. So we do the Depo-Provera. Depo-Provera is the one, is helpful, and then I have been having a good luck. And good thing about Depo-Provera is does not have much side effects, tolerable. So I usually go like 150, 300, 450. And then we have some patients ended up giving 450 every week. So I just start one injection and we monitor. And then like low dose, 150, every 4 weeks. Okay, still have it every 3 weeks, then titrate. So either I kind of go back and forth between the dose and the frequency.
Okay. Is there something I can use documentation for my medical director?
About Depo-Provera?
To get him on board with that use.
Yeah, documentation is like, most of these are things we do as like off-label, but Depo-Provera is like, we don't have like a FDA approval, but it is indicated. And then there is a lot of clinical data also suggesting that it's been using sexually inappropriate behaviors in elderly patient population.
Okay, thank you.
Yeah, and just want to add one more point is because some of the time in the past, they used to use the estrogens. Those are not good because it has some cardiac toxicity. So the estrogens are not good for the sexually inappropriate behavior. But Depo-Provera is safe and it's effective. Yeah. Any other questions?
If there's no one else, I wrote down a question because I'm just genuinely curious. When it comes to standing orders for psychotropics, would you encourage facilities to have their medical director look into having standing orders for, like, if they're on Depakote, liver function tests, CBC, every month, every 3 months, every...
Yeah, there was like labs there is like a standing orders for the labs, like 3 months, CBC, LFTs, and lithium. We do have those. And then now with the psychotropics being done, we need to have the lab monitoring. So we try to making it as a standing order too. So get the labs done because...
I just know they get forgotten quite a bit. So I think that would be helpful.
Everything is 6 months, at least twice a year if they're stable. And then for acute issues, we want current labs.
Yeah, I do not prescribe lithium, but if there is an already in lithium, so we try to check the lithium levels, and no matter what, it is like a pre. I mean, that's why most of the primary care don't like us, because being a psychiatrist, why do you need the labs? So, but, we need the labs for many reasons. So, our standard is like all initial level, even they come from the hospitals, we get the labs done, and then after that we'll just keep reminding whenever there is a GDRs, we just kind of follow. She keeps track of those things. That's why I think she kind of jumped into that to answer that. So who is needed, who is not having the labs, and then she reminds me. And even though primary care won't do it, we make sure for whenever they are on psychotropics, we wanted to get the labs done. Okay. So thank you very much, and thank you, Jennifer, thank you, Santana, and thank you for QSOT's team, and thank you all for your attention. Hope have a safe trip back to homes, and bye-bye.